Okay, now I'll break down age groups that are common for meningitis in a similar way as we did for pneumonia. In newborns, meningitis is most often caused by the same bugs causing pneumonia, group B strep and E. coli, plus listeria. Again, it is helpful to remember that B is for babies. In all the other age groups, strep pneumonia is the most common cause of meningitis. This is a favorite question on the boards, because largely due to its name, people don't associate strep pneumonia with meningitis. Remember that it is. Children below the age of 6 years are most likely to get meningitis from strep pneumonia, Neisseria meningitidis, Haemophilus influenza type B, and enteroviruses such as Coxsackie. Haemophilus type B, also known as Hib, as I've written it on the slide, is now very rare due to immunization. Meningitis in older children and adults is most likely caused by strep pneumonia, Neisseria meningitidis, enteroviruses, or HSV. Neisseria meningitidis is the most common cause in high school-aged people, people living in dorms or in the military, while strep pneumo is much more common in adults over 30 years of age. Lastly, in patients over the age of 60, strep pneumonia is still common, but now we also have gram-negative rods and listeria. So how do you treat suspected meningitis? If you suspected meningitis, you need to treat with ceftriaxone and vancomycin. So why do you need both? Well, vancomycin can't be administered alone because by itself it has poor penetration across the blood-brain barrier. So you're going to add a third antibiotic, namely ampicillin, if you're concerned for listeria in the very young or elderly. So, in a newborn with a suspicion for meningitis, you would give ceftriaxone, vancomycin, and ampicillin. Now, we've heard the term aseptic meningitis before. Again, aseptic meningitis is any meningitis where the causative organism cannot be cultured on routine bacteriologic media. These include viruses. Viruses that can cause meningitis include enterovirus, especially Coxsackie virus, herpes simplex virus, HIV, West Nile, and varicella zoster virus. Patients with HIV can have cryptococcus, cytomegalovirus, toxoplasmosis, or JC virus infection of the central nervous system. Let's briefly talk about the related but different entity, encephalitis. What causes encephalitis? Some viruses to remember include the arboviruses we talked about before, West Nile virus, which is the most common arbovirus in the US, Eastern equine, Western equine, St. Louis encephalitis virus, rabies, and HSV1. On the boards, the most commonly tested cause of encephalitis is HSV1, which causes a specific type of encephalitis known as temporal lobe encephalitis. How do you detect HSV1? You use PCR of the spinal fluid to test for HSV1. You should take a look at the neurology section for clarification of encephalitis. Do you remember what bug can cause life-threatening meningoencephalitis that has very poor prognosis and is associated with diving into ponds? Naegleria fowleri. You'll learn more about the difference between meningitis and encephalitis later in neurology, but bear in mind that a key difference is that in encephalitis, where the brain parenchyma is infected, you'll see mental status changes. Meningitis has typical symptoms of nuchal rigidity, headache, and photophobia. Let's take a look at this table that indicates the effect of meningitis on several lab values and the differences seen in meningitis caused by bacteria, fungi, and viruses. For the boards and beyond, this is high-yield information to remember. They like to test this. First, let's discuss the process to diagnose meningitis. When meningitis is suspected, you do a lumbar puncture, also known colloquially as a spinal tap. You can see in this image that the site of lumbar puncture is usually at L4, L5, L5, S1, or higher at L3, L4. You can see here that the spinal needle is inserted between the lumbar vertebra and is pushed in past the ligamentum flavum and the epidural space, past the dura mater and arachnoid mater, and into the subarachnoid space. When it is in the subarachnoid space, we can measure the opening pressures, which is literally the pressure obtained by a column manometer when we first enter the subarachnoid space. You can see here that CSF pressure increases in meningitis caused by bacteria and fungi, and sometimes even in meningitis caused by viruses. To remember this, just think that the bacteria and fungi are taking up more space, putting more pressures on the volume of cerebrospinal fluid. Viruses are much smaller and take up less space, so sometimes they don't change the pressure at all. In bacterial meningitis, you'll see an increase in PMNs, also known as neutrophils. This is because neutrophils are the main cell type involved in killing bacteria. On the other hand, in fungal and viral meningitis, you'll see an increase in lymphocytes because these are the main cell type involved in killing these types of organisms. Protein levels will increase in both bacterial and fungal meningitis and can either increase or don't change in viral meningitis. You can remember this by thinking that bacteria and fungi have a lot of protein, and therefore, if they're in the CSF, there will be more protein in the CSF also. Out of all of these, the one category that will help you diagnose bacterial versus aseptic meningitis is the sugar levels in your CSF specimen. Sugar, or glucose, is decreased in both bacterial and fungal meningitis, while it will be normal or even increased in viruses. The way I like to remember this is to just think that the bacteria and fungi are consuming all the glucose, whereas the viruses don't consume sugar. I'm helping you to drill this in. The most common all-round cause of meningitis is what? Right, strep pneumo. Let's start with an image of osteomyelitis. This is an X-ray showing osteomyelitis of the tibia of a young child. The osteomyelitic areas are seen as radiolucency on the X-ray. Osteomyelitis is another disease that can be caused by several different pathogens. In most people, unless you have reason to believe otherwise, the most common cause of osteomyelitis is Staph aureus. However, in several other types of patients, other organisms can be more common. Let's go through these. In sexually active individuals, Neisseria gonorrhea can cause osteomyelitis. However, this is rare. It's more likely to cause septic arthritis. Diabetics and drug addicts can both get osteomyelitis from Pseudomonas aeruginosa and Serratia. Patients with sickle cell can get osteomyelitis from Salmonella. Patients with prosthetic replacements can get it from Staph aureus and Staph epidermidis. To remember this, think of contamination of the blood from bugs on the skin. Osteomyelitis of the vertebra can be caused by Mycobacterium tuberculosis, in which case it is called Pott's disease. Lastly, cat or dog bites or scratches can carry Pasteurella multisoda, which can also cause osteomyelitis. Most of the time, you'll see this disease in children. Let's start by having a schematic of the urinary system so we can visualize where the infections can occur. A urinary tract infection includes infections within the urethra, bladder, or kidney. However, because the organism that causes infections of the urethra are sexually transmitted, they are usually considered STDs or sexually transmitted diseases, and not UTIs. Let's start with cystitis, which is infection of the bladder. Patients with cystitis often present with dysuria, frequency and urgency, suprapubic pain, and white blood cells, but not casts in their urine. These patients will generally not have systemic signs like fevers, chills, or sweats. This is different from pyelonephritis, which we'll discuss in a second. The most common pathway for infection of the bladder is by ascension of microbes from the urethra to the bladder. And therefore, UTIs are more common in individuals in whom it's easier for the pathogen to get from the urethra to the bladder. So, for example, in males, UTIs can be common in infants with congenital defects or vesicoureteral reflux, which is reflux from the bladder into the ureter. It's also more common in women because they have shorter urethras, which can also become colonized by fecal flora. Some other predisposing factors include obstruction that can cause urinary stasis, which will allow bacteria to grow, kidney surgery, catheterization, which provides a direct path for bacteria to enter the urinary tract, GU malformation, diabetes, and sexual intercourse, since this can introduce bacteria into the urinary tract. Finally, pregnancy is another cause. If UTIs ascend even further, they can ascend to the kidneys, which may result in pyelonephritis. In contrast to infection of the bladder, pyelonephritis results in systemic symptoms including fever, chills, flank pain, CVA tenderness, hematuria, and white blood cell casts in the urine. In children with vesicoureteral reflux, chronic pyelonephritis causes fibrosis. So how do you diagnose a UTI? To diagnose a UTI, you use two tests, the leukocyte esterase test and the nitrite tests. The leukocyte esterase test tests for white blood cells in the urine, while the nitrite test is more specific for gram-negative bacteria or Enterobacteriaceae. You can also culture the urine to grow the bacteria. How many organisms are needed to qualify as bacteriuria? 10 to the power 5, or 100,000 per milliliter, is considered significant bacteriuria. However, if the patient is asymptomatic, you wouldn't treat. An exception to this is asymptomatic bacteriuria in pregnant women, where you always treat. Another exception is if a patient has less than 100,000 units, but has significant symptoms. As promised, here are the bugs most likely to cause UTIs. E. coli is the leading cause of UTIs. Do you remember what virulence factor helps E. coli cause UTIs? Yes, Fimbria or pili. These pili bind to digalactose receptors or urinary mucosal cells. Next is Staphylococcus saprophyticus, which is most often seen in sexually active women. What is the most common cause of UTI in a young female? It's still E. coli, not staph sap. In third place is Klebsiella pneumonia. Other causes of UTIs are Serratia marascens, which on culture can produce red pigment. Remember the maraschino cherry. Enterobacter cloaca is often nosocomial. Proteus mirabilis shows swarming motility on agar. Finally, Pseudomonas aeruginosa has its characteristic fruity odor and has blue-green pigment. Do you remember which enzyme Proteus produces? Yes, urease. This gives urine an ammonia scent. Also, with Proteus, keep in mind that alkalinization of the urine by the ammonia predisposes the patient to struvite kidney stones. Sometimes, knowing the patient's history can help you narrow down what kind of UTI bug they have. For example, Serratia, Enterobacter, and Pseudomonas are all commonly nosocomial, so a patient who has recently been in the hospital and now has a UTI is likely to have one of these. Likewise, a patient with struvite stones who also has a UTI is likely to be infected with Proteus. Another bug you can consider is adenovirus. If the UTI is accompanied by hematuria, especially in children, think adenovirus. One last thing, UTIs in patients with indwelling urinary catheters are often caused by Candida albicans. Let's just go over the diagnostic markers. When leukocyte esterase is positive, it indicates there is a bacterial infection. Nitrite will indicate the colonization is by a gram-negative bacterium. The urease test is used to indicate there is a urease-producing bug, such as Proteus or Klebsiella. A negative urease test is suggestive of colonization by E. coli or Enterococcus, which don't produce urease.